First of all, I want to thank SAGES and our chairs, Dr. Crow and Dr. Alsabah, for the opportunity of being here. I'm going to talk a little bit about how to maximize outcomes as we move into some of the endoscopic bariatric procedures, mostly focused on pre- and post-operative planning. I have no financial disclosures for this talk. So the objectives are going to be to talk about some of the factors that can help us get the best results for our patients. And I want to divide these in three different areas. The first one is going to be obviously the most important one, which is the patient, but also talk a little bit about the professional team and the procedure itself. So just a little bit of background. We know that obesity has been a growing epidemic for many, many years. But when you look at the growth of bariatric surgery, I think there's been a big discrepancy. About a third of the population in certain parts of the world is obese, but we're only reaching about 0.01% of the patients for bariatric surgery. When you look at different regions, it's pretty interesting, I think, that in 2003, we did more bariatric operations than we did in 2011. So even though there's been some growth, I don't think the growth has been in parallel with the obesity epidemic in general. So there's been certain explanations that have been brought up to explain this discrepancy. Some people talk about barriers to access, patient fear, some insurance hurdles which we struggle with on a daily basis, and also socioeconomic hurdles. So I think talking about endoluminal bariatric therapies is a way that we think we can narrow this gap. And when you look at how we approach obesity and you look at the risk and the efficacy of certain things like medical therapy and surgical therapy, I feel that what we're trying to do with endoscopic therapy is to kind of fill this gap between these two big areas. So how do we get there? I think planning, especially as we introduce some newer procedures, is key. I think right now we're still at the very early stages of some of the endoscopic procedures, and there's a lot of work to do to make this a little bit more universal. So talking a little bit about patients, I think one of the big things that we have in our practice is that our payers have really set the rules for the game. So how much time patients spend getting preoperative nutrition before they go to bariatric surgery has been set more by insurance rules and not really what we think is best for our patients. So I guess the question is, now that we have new payers, does this mean we need new rules? And I think the key is that we need to follow the same evaluation patient selection principles to make sure that the new procedures that we're introducing to our practice are going to have the best result. Now, I think for us as a community, we're willing to accept lower efficacy based on that graph that I showed you for primary endoscopic therapy, but I don't think this means that we can lower our threshold for accepting patients for these therapies. So what have we learned from our bariatric patients? You know, these patients are really different in terms of their behavioral and psychological status. There's a very high incidence of anxiety, depression, other emotional problems. Some studies go to 50% incidence. They have special eating patterns, you know, some newer syndromes that have been described, like the night eating syndrome or binge eating disorder. And a lot of these preoperative factors that can be diagnosed and treated have huge implications on postoperative outcomes. And the same is true for follow-up. I think, you know, when we do these newer procedures, we have to follow the same principles that we do for what we know right now as bariatric surgery. You know, we got to make sure these patients are coming back either every month or every 3 months and seeing at least somebody from the bariatric team. When you look at the association between adherence to a bariatric program and weight regain, there's a clear difference in terms of patients that are not following up and how they regain weight and they basically fail their objectives of operations. So moving forward a little bit, talking about the team, I think this is probably the most important take-home message of my talk, is to understand that these newer therapies have to be done as part of a multidisciplinary team. And you know, this team needs to have nursing support, behavioral and psychology support, obviously nutritional and physicians. And for the proceduralists that are going to be doing these endoscopic therapies, they have to be ready to do the initial intervention, but they also have to be ready to treat some of the complications that may arise from them. When we talk about the endoscopist as the main person doing these procedures, and kind of following a little bit what Dr. Chan talked about, there has to be proper training and proper credentialing. And I think that there's two big components to what training is. Obviously, there's a technical component in terms of how to learn these new procedures, these new technologies, but also there's a clinical component for a lot of people that are not bariatric surgeons and are not bariatric trained. I think you have to learn the ins and outs of running a bariatric practice and how to approach these patients, which can sometimes be very challenging. So the key is to be part of a comprehensive team. Just following a little bit on the white paper that was published by the ASG and ASMBS Combined Task Force, some of the points that were made is that endoscopic bariatric therapy should be part of a comprehensive and multidisciplinary program, and I can't emphasize this enough in terms of what the success is going to be. It should also induce enough weight loss to decrease the weight-related comorbidities and improve the quality of life. Now, the risk-benefit profile is a little bit different because it's very dynamic. And I think this is a big part of the discussion that the physician needs to have with the patient, is to set realistic expectations and explain the risks, the benefits, and the alternatives that we have for management right now. So I think for procedures that are intended to induce a low excess weight loss of 10 to 20%, the risk should not really be any higher than therapeutic endoscopy, but this risk can go a little bit up as we move to procedures with better results. I think we as physicians have a social and a clinical responsibility, and there's obviously a little bit of a bias in some of these self-pay procedures that are coming out, and I think it's important that we maintain our principles to do what we think is best for our patients. There's a bunch of these billboards that are showing up all around, and I think we have to be careful in how we select patients and how we move forward. In terms of the procedure itself, every facility is going to have a little bit of a different profile in terms of cost and what the best scenario is for performing different endoscopic therapies. So there has to be a clear discussion between the cost of doing it in a certain setting and the safety behind that setting. Facilities need to be equipped with proper bariatric equipment, both for the preoperative and postoperative areas. And I think for everybody, the proper setting is going to be a little bit different, especially early in the learning curves. I think an OR setting with good anesthesia support and endotracheal intubation is probably going to work best than conscious sedation in an endo suite. For the team, I think there's a real learning curve to many of these things, and everybody needs to participate. The anesthesia team needs to be clear about what the procedure is, what the risks are. The nursing team needs to be trained on the equipment itself, and obviously the endoscopist needs to be a key part in this. In terms of the equipment, I think different therapies require different equipment, and we have to be sure that we are equipped with that. In terms of endoscopes, many of these procedures can be done with a regular diagnostic endoscope, but some others will need therapeutic endoscopes with either 1 or 2 working channels. Different energy sources, procedure-specific equipment, and obviously anticipate pitfalls. So in summary, there's a huge gap between the obesity epidemic and surgical treatment. Hopefully, endoluminal bariatric therapy has a promising and growing role in this area. It should be offered as part of a multidisciplinary approach, and the pre- and post-procedural planning can help optimize outcomes. Thank you very much.